It's pain in my head. Nobody's able to diagnose me. I'm falling through the cracks. You very well could have central sensitization. My whole thing was give me a non-drug measure. So I found spinal cord stimulation. And right now, today, I have a spinal cord stimulator that was implanted in 2014 that helps to disrupt that top-down pain approach. That signal that my body was trying to tell me back then is pay attention to me. Don't just go naturopathic medicine, get married, work till you're like dropping, basically. Listen to me, body. Like my body was crying out.
Screaming for help.
Screaming for help.
I mean, you went through so much. Like you said, it was almost, failure or lesson after lesson. What would you say that should have been done differently that now in 2025, how should this be diagnosed?
Welcome to another insightful episode of the Uncover Your Eyes podcast. I'm your host, Dr. Meenal Agarwal. If you haven't hit the follow or subscribe button, I encourage you to do so. Let us know that you are listening. Today's episode is a powerful blend of science, lived experience, and compassion. Today's guest is Dr. Shabita Teja, a naturopathic doctor and a pharmacist. She was also one of the first patients in British Columbia to receive a spinal cord stimulator for chronic abdominal pain for a condition many still struggle to name, central sensitization. Chronic pain affects almost 1 in 4 adults globally, and women are disproportionately affected. And a lot of the times we're told it's just all in your head. But what if it's in your nervous system? From fibromyalgia and IBS to migraines and trauma-induced pain, this condition touches millions, yet remains widely misunderstood. Let's unpack central sensitization.
Welcome, Dr. Teja. Thank you so much for being on today.
Thank you for having me. I'm excited to have this conversation.
So tell me, I had never heard of, central sensitization, such a big word. And, I really didn't realize like there was such a high stat on chronic pain sufferers, 1 in 4 globally. And I didn't realize women are disproportionately affected. So what does chronic pain and central sensitization mean? Are they different? And how do you know you have one or the other?
Yeah, I mean, that's a great question. And I will also dive into my own story throughout the
Absolutely.
episode. So just to let you know that you and your listeners know that I personally do have chronic pain, central sensitization. So your question about the difference between chronic pain and central sensitization. Chronic pain, just to orient ourselves, I would say is an overarching diagnosis that a lot of additional diagnoses can fall within. So you might have chronic pain, but what's the particular diagnosis? Maybe it's migraines, maybe it's irritable bowel syndrome, maybe it's fibromyalgia. Central sensitization is one of many different chronic pain syndromes. And chronic pain really is just not acute pain. So acute pain is something like I stubbed my toe or I, tore my ACL, the knee ligament, and now I need surgery. I'm in acute pain. So usually it's less than 6 weeks, between 2 to 6 weeks. Anything longer than 3 months is going to be chronic pain. And that can be whether it's chronic nerve pain, chronic musculoskeletal pain, ligament injury. So central sensitization is an over exaggeration of your nervous system where that fire alarm is, continuing to ring despite there being no fire. So that metaphor is akin to your pain. The pain response is long gone. The pain is long gone, but your nervous system acts as if it's still there. And so that's really in a nutshell, what central sensitization is and how that's different from just general chronic pain.
So if you have any conditions, really you can experience central sensitization with any of these conditions, if I'm understanding correctly. It's just a matter of that you're oversensitive or that pain is lasting longer in any of these conditions, including fibromyalgia, IBS, all of them, correct?
Correct. Yes. I would say so. I got diagnosed back in 2011, I would say between 2011 to 2014. Now, the reason I don't have a particular date is because it is so difficult to diagnose central sensitization. Because how do you determine whether this person has central sensitization or not versus just maybe they're more sensitive, maybe they have had, a more severe injury. So central sensitization is very particular and it takes a while to be diagnosed. I will say in today's day and age, in 2025, when this podcast was recorded, we have more knowledge of what central sensitization is and some of the diagnostic criteria and requirements. So it's not that everybody can have central sensitization, but that word, that condition is there's just more awareness around that. So people back in 2010, it wasn't as easy to have a diagnosis of central sensitization. Really, those patients were the ones that fell through the cracks or had that term of it, the pain is in your head, or you have depression, anxiety, and the pain is not real. So I would say it's more common in that patient population.
Okay, I love that you said the pain is in your head, because that kind of leads me to wrapping my head around the process more anatomically. So, if you're experiencing pain
Mhm.
and the pain is not there, but it's still sending signals to your nervous system, like, how is that happening? Walk me
Yeah,
through that
yeah,
process.
for sure. So, pain, let's take it back to acute pain. You touch your hand on a stove and you immediately withdraw it. Your brain is going through a bottom up approach, meaning that stove that you've touched is hot. You're touching your hand to it. The neurons fire to your brain and it says pain, immediately withdraw. That's a feedback loop, right? It's quick and it's over and done with. Now, the more that we're getting, more and more knowledge about pain, we're understanding that not only do we have a bottom up approach, we have a top down approach, meaning that the brain and the emotional processing near the brain and different brain areas like the anterior cingulate cortex, the insula, the amygdala, these are areas of the brain that deal with both pain and emotion. That top down approach affects how that person, that patient, interprets the pain. And this is more so for chronic pain that has gone on for longer than 3 months. So not only do we have that bottom up approach where it's very quick and we have the neurons firing to our brain, we now have top down issues with pain processing and our pain perception, because it really comes down to not just the pain, is if it even is pain, it's what is how are we perceiving the pain, if it is, or that sensation, do are we registering it as pain? For example, like the insula, the amygdala, they're so closely, location wise in our brain is closely linked to memory, to smell, to trauma. So now our pain processing centers are very closely location linked to these areas of the brain, that maybe it's a smell memory, maybe it's a traumatic episode that now is etched in that brain center, and pain very quickly turns into a whole laundry list of feelings that deal with, depression. And now we hear about post-traumatic stress disorder, phantom limb pain. I mean, the list goes on, and we're getting more research, more evidence, more anecdotal reports. All of this is helping our learning in the medical community. I can say that with my sister being a conventional medical doctor and myself as a pharmacist and naturopath in the naturopathic medical community, we are learning a heck of a lot more about how pain is processed in the body and who is sitting in front of us now as a pain patient. They have it's not in the head. I mean, it is in the head,
Right.
literally, it is
Yeah.
in the head,
Yeah.
but it's not in the head in terms of there's nothing we can do. There's a heck of a lot we can do. So that's sort of the bottom down approach, the top down approach, excuse me, and the bottom up approach of pain. And if you like Google, how do I process pain, or tell me about how pain is processed, you might come across the Melzack wall theory of pain, the gate theory of pain. And this was back in 1965. So that's sort of the old processing of the acute pain description that I described. So we now know a lot more about how pain is processed in the body.
And okay, so is the issue in the brain? Like, are these areas not talking properly? What or is this a genetic link in the brain? Like, what is happening in the brain that gets altered such that it's a top-down approach?
Yeah, so good question. So like any other condition or disease, you either really have two areas of manipulation, genetics or environment, right? So yes, there can be genetics that cause me as a central sensitization patient or person that's dealing with central sensitization to experience pain more deeply, right? Maybe there, and it comes down to neuroplasticity. So that word is a big word. Neuroplasticity is our pains processing and those neural pathways that are developed over time. Are they more etched genetically, or is it environmental? Meaning, was it a past condition that happened, a stressful condition that happened associated with the pain that now makes my brain interpret anything that's similar to that situation as a 5 alarm fire? So genetics, we can't really do anything with, right? You're born with what you're born with. We can help environmentally with the neuroplasticity. And that is where things like cognitive behavioral therapy come into play, mindfulness, breath work. And manipulating our nervous system so that we're not in fight or flight. We're more in rest and digest where healing happens. Because fight or flight is protective to us. It's that immediate bottom up approach where we've touched the hot stove and now we're moving our hand away, or being chased by a lion. All blood flow is going to our limbs. Our pupils are really dilated so we can see far. There is no sex going on. There is no healing going on. There's no blood flow to your core. Nothing's about digestion. Nothing is about feeding things that make us look and feel good, like our hair and skin and nails. None of that matters. We need to escape the lion. So you can imagine, now we're not being chased by a lion, but we have deadlines, we have meetings, our boss is calling, our kids need us. We have X, Y, and Z. And as women, we have a laundry list of things in our things to do list that make us feel like we're being chased by a lion repetitively throughout the day. So we're not in a state of healing. We're not in a state of rest and digest. We are constantly in that fight or flight without any sort of loop to close that loop, to close that, again, with the stove, that loop is closed. Once I remove my hand, my body can move on to the next thing. But we are in a constant state of low grade stress with bursts of I'm being chased, I'm being chased, I'm being chased, without
Right.
any restoration. When you see a lion yawn or a dog shake, they're restoring their nervous system, that they're closing their loop that way. And we don't have anything practically to do that. Naturopathic medicine has got a ton of things, but day to day, there's not a lot. And that's why people then have these well-formed pathways in the brain, and makes it so easy to experience that pain.
Right.
Right.
How do we know we have this condition? I mean, it's like you said, it's so difficult to know, and probably getting diagnosed much later. A lot of the times we probably think it's in our head, or we're just experiencing pain because we are in pain.
Yeah.
So what are the symptoms for people to be alerted, or for us
Yeah.
to be alerted to tell our patients?
Yeah, for sure. So I would say, first of all, if you've had pain that's longer than 3 months, that is a disproportionate to the injury or stimuli. So, for example, I hit my ankle rollerblading, and now that pain that should have been resolved in 2 weeks is now longer than 3 months. And not only am I feeling that pain around my left ankle, I'm feeling it in my right ankle. I'm feeling it in my right wrist. I'm feeling it down the side of down my body. I am now feeling around the ankle area that pain is disproportionate to the injury. The pain is getting worse. So that stimuli, that rollerblading accident, it's disproportionate. The pain that I'm feeling is disproportionate to the injury. That's probably the number one
And
way.
it's referred, I guess. It's referred pain as well. It's
It
referred to
can
other areas.
be referred pain, exactly. And it's not, and it doesn't follow the dermatomal pattern. So this is what's puzzling to medical professionals that also aren't keeping up, maybe. And it's hard to keep up with medicine. It's always changing. But it is hard to keep up if you have a doctor that maybe is not even aware that central sensitization is a thing. I will say for your listeners, complex regional pain syndrome, or I just forgot the word. Yeah, CRPS. That is something that was sort of the older definition back in the 90s, the early 2000s, that you would hear quite a bit. And so if you have something like that, you can bring this to your doctor and say, have you heard of central sensitization? Does this sound like what I have? Or if you're not aware of it, are you able to refer me to somebody that does? This is why I love what I do. Is I feel that doctor is teacher, one of the principles of naturopathic medicine, is something that I do every day in practice, where I'm equipping my patients with education so that they can be a better advocate for themselves.
Advocate.
So that's number one. And then getting back to your original question, pain disproportionate to the injury. You can also have things like hyperalgesia and allodynia. So those are two pain specific definitions. Hyperalgesia is a response to that pain that's greater than the actual injury. So that's a medical term for that. Allodynia is a painful response to a non painful stimuli. So something like my shirt brushing against my arm, it's feeling like my arm is on fire. That is not a painful stimuli, but I feel pain towards it. That is allodynia. If you are hearing terms like this, if you right now listening to this podcast feel like that's exactly, you're describing me, you could very well have central sensitization. But I also don't want to be fear mongering to your listeners to say everybody has central sensitization. This is longer than 3 months. This is something that you've been to every doctor and again, it's pain in my head. Nobody's able to diagnose me. I'm falling through the cracks. You very well could have central sensitization. And this is, let's not mistake it for a mental emotional diagnosis, because depression, anxiety, mental health disorders are very real. And you could experience pain disproportionate to your injury without the other things, just because you have depression, major depressive disorder, or generalized anxiety disorder. So I also see patients in practice where they are so, everybody's a Google doctor or on TikTok or Instagram. You feel like this resonates with me. It's definitely what I have.
Yeah.
Don't also jump to that conclusion to say, I have central sensitization and I want to find a community. Find that community, but don't wear that label if
Right.
that's not truly what you have. So I just want to do both, like have both sides of the coin sort of featured here, and make sure that patients and your listeners are aware of that.
I mean, when I listen to you, I'm like, this is painful, especially, the story about like you're putting on your shirt and it's like it's on fire and you're not on, that's not the case, right?
Yeah.
You've lived this.
Hmm.
What does it feel like? And how long, like, have you experienced this? Is this since you were a teenager or like in your early 30s? Like, how long have you experienced this and how debilitating is it?
Yeah, it's yeah, very debilitating. And I was mentioning CRPS, and when I got diagnosed back in 2011, 2014, around that time, it was a very challenging time, because I was that patient that nobody knew what was wrong with me. I was in and out of hospital, in and out of pain clinics. And for a second, a doctor might know what's wrong, and you go down that rabbit hole, and then it's like, no, your symptoms are changing, or nothing is getting through to the pain. You're a difficult patient, or you're a complex patient. And I hate that term because it's triggering to me. But now, because dealing with what I've dealt with, I can say that everybody is doing the best they can. Medical doctors are doing the best they can. Specialists are doing the best they can. They're operating with the information they know. And I think back then we didn't know enough. And so I definitely went through a really difficult time. So I'm 41 today in 2025. I got diagnosed with ulcerative colitis back when I was 19. So about, more than half my life now, I was healthy as a horse before that, never any issues at all, like besides the, common cold. Healthy during high school, healthy during childhood, all of that, like, classic, perfectly fine. I wake up one morning and I have blood in my stool. I've, dropped 20 pounds over the Christmas break between grade 12 and going into my first year of, I did general sciences at my local college before going to university to study pharmaceutical sciences. And it was like, what is going on? Luckily, because my symptoms progressed so quickly with ulcerative colitis, I got a diagnosis earlier than most. But on the flip side of the coin, my progression was very quick. And so from mild to moderate ulcerative colitis, I progressed to severe within a very short period of time. So 2002, I get the diagnosis. 2004, I have my ileostomy. So my colon was removed. So I won't go through every detail and like all the meds and everything that I was put on and failed. But my colon was removed in 2006. I had the reversal, meaning I have a J pouch now, but I don't have a colon. And my small intestine functions as sort of a both small and large intestine. So they create a J from the latter end of the small
Right.
intestine. Right. So I deal with, and especially 2006 to I'd say 2020 even, I'm dealing with how does my diet look different? How does my electrolytes, hydration, all of that change now that I don't have a colon? I was fine. I finished pharmaceutical science. I became a pharmacist. And then I start to get not lower abdominal pain that I was used to with ulcerative colitis. I'm getting epigastric pain now just below my breastbone. And I'm like, this is new. I'm getting nausea, vomiting. And it sounded like to the medical doctors in ER, which again, they're triaging for like, are you dying or are you not? So if you're not dying, we'll, get you out of here as quickly as possible, get you on your way with pain meds. And then I was sent to general surgery that said, an upper GI surgeon, because my lower GI specialist said, no, you need to go to upper GI. And now, as a naturopathic doctor, that is so crazy to me because the body is a whole and we are compartmentalizing not even the gastrointestinal system, we are compartmentalizing upper and lower GI. So fast forward, I get my gallbladder removed. And my mom still remembers this, that I was on the table before getting wheeled into surgery. And I said, Mom, what if this doesn't help the pain? And it was my gut telling me that this is not the solution. And I wake up from that surgery, pain not gone. And I'm just like in an enormous amount of pain because my body was like, what is happening? You're removing now another organ. A year after that, I get my nerves removed because like I mentioning, doctors think they know, okay, we know that you have neuralgia. We know that you have intercostal neuralgia. The neurectomy, removing 3 nerves on my right side, is going to fix the problem. So we remove that. I wake up screaming in pain because now knowing what we know, the nervous system is saying, this 5 alarm fire, you've turned it into like DEFCON 5. Like what is, so it was just, failure after failure. But now I look back and think it's lesson upon lesson. So I was in a really dire situation there and I'm just, newlywed. So during this time I get married, I am started naturopathic medicine, but I have to take a leave because I couldn't finish my first year. And my husband, the saint that he is, like, just stuck by with me throughout everything. And I knew then that he was a keeper when I told him dating that, I have an ileostomy, and he didn't flinch. Like, oh yeah, that's, show me it. Like, so we have to surround ourselves with those people that are there for us as
Awesome.
a soul, positive influence, there no matter what. And you quickly learn who your friends are and who your circle is. So that this is not even the pain part of my story, but so I'll go through it quickly. 2009 is when I had the gallbladder surgery. 2011 was when I had the neurectomy. And 2011 to 2014 were very tough years. I went in and out of hospital 5 different times, 3-week stints each in hospital care and part of an inpatient pain program. I was on IV ketamine for those 3 weeks. IV ketamine, we can talk about in a bit here, but it really just shuts down your nervous system. So I loved it. I was like, I can, walk around with this IV. If you send me home with this, I can finish naturopathic medicine. I'm good. But it was artificial because as soon as I came off of it, the pain started again. So it was a clue then, but we didn't know enough about central sensitization. My pain doctor at the time said, do you have CRPS? You don't really sound like that type of patient because yours is epigastric and we really deal with limbs, like the rollerblading
Right.
example I gave earlier. So I wasn't fitting anything. I was doing ketamine comas where they would take me under, and it's one step one step above death, rather, where they're putting me in high dose ketamine comas for a couple hours to shut down my nervous system, thinking that the IV ketamine helped. Let's give you even more. That worked for maybe a couple weeks. So better, but not long lasting. Meanwhile, I'm taking opioids, I'm taking methadone at the same time because we're just trying to stop the pain. My body was in that on fire
Right.
state. And so, I'm in a constant state of learning. I was at the time in naturopathic medicine, and my whole thing was give me a non drug measure. So I found spinal cord stimulation. And right now, today, I have a spinal cord stimulator that was implanted in 2014 that helps to disrupt that top down pain approach, and help to break that loop. So I do have a spinal cord stimulator that has helped me get off of a number of medications. In fact, the methadone, the Percocet, no more IV ketamine, no more ketamine comas. So that is a non-drug measure that has definitely helped me. But it was only part of my story. And I'm continuing today, sitting here, July 16th, 2025, on an emotional journey of this pain has an emotional component that I wasn't ready to hear back then when my body was on fire. So now when things have calmed down, now when I'm, off of the drugs that muddle you and have, fog upon fog, now I can start to say, okay, breath work helps, dealing with my emotions help, giving myself autonomy and not adapting every time to everybody's wish and trusting my gut, being authentic to myself. I mean, it sounds woo woo, but it really does help. And it's helped me so much to now get to a point that I might not even need my device. I might not even need my spinal cord stimulator anymore because that pain, that signal that my body was trying to tell me back then is pay attention to me. Don't just go naturopathic medicine, get married, work till you're like dropping, basically. Listen to me, body. Like my body was crying out and I
Screaming for
wasn't
help.
screaming for help, literally. So that is sort of, yeah, I've gone through a difficult time, but it's been lessons. And now I'm in even a better, more grounded state. And I'm continuing, like the lessons are still happening, which they should. But I get to help my patients now, and meet them where they're at, because I see patients that were like me in 2009 and are like me in 2025, and I all in between, and I meet them where they're at, and I now have the tools that are in my toolbox that I help with them. But everybody's different, and timelines matter. So yeah, I know I took a long time, but that is like
Wow, no, that's
really,
powerful.
yeah.
You lived through it. You gave me goosebumps. I think what these patients like yourself that are struggling with it, I mean, you went through so much. Like you said, it was almost, failure or lesson after lesson.
Yeah.
Um, what would you say that should have been done differently that now in 2025, how should this be diagnosed? What are the tests? Is it just purely symptom based? How do you know you have this? And what tests can you self advocate for to your doctor?
Yeah, great questions. There are a couple. There are the pain scale, right? So there's a pain scale. There is a specific central sensitization inventory, so CSI, and your pain inventory. So like a pain scale, that it'll just go 0 to 10. How am I feeling? And most people have had that asked of them. What that doesn't take into account is what CBT preaches or helps with the rumination, catastrophizing, maximizing, or minimizing, or magnification. So these types of cognitive behavioral therapy terms are included in the CSI, are included in the central sensitization inventory to kind of pick patients that might fall through the cracks otherwise in just a general pain scale, objective measure, basically. So you can ask for that. You can ask for a CSI and say, am I a type of patient that am I somebody that central sensitization is even something that should be on my differential diagnoses. Um, I will say, and I mentioned fibromyalgia, migraines, IBS off the top. You can have those conditions without having central sensitization.
Right.
It's that you can have them plus central sensitization too. And these are the patients that have chronic X, Y, and Z after that. So chronic IBS, chronic migraines, chronic pelvic pain syndrome. These are not acute situations. This has been going on for long term, and now we have central sensitization as a diagnosis. Again, I want to be very careful about not, having this catch-all diagnoses for chronic pain conditions. And something that I wish somebody would have told me back in 2009, 2010 is breath work is important, yes, but looking at the mind, body, spirit connection as a whole. And what I mean by that is your emotions matter. And if somebody had told me back then about the anterior cingulate cortex, I was in pharmaceutical sciences, I would have gotten it. I would have understood insula, the insula, the amygdala, and understanding that it's not just that acute pain feedback loop, that we have a top down approach, that inflammation matters. Our inflammatory cytokines, these little signals that are released from the brain that tell us to amplify, that tell our body to amplify the pain signal or not, that all matters. Our gut matters, right? The gut brain connection is huge. So if somebody would have told me that, and now we know so much more about that. So it's like, lucky to be in this day and age where we know more and we can save patients from unnecessary surgery. Because again, surgeons are doing what they know, and they're
Right.
needed for acute emergency situations. But you don't need to take something out that has an emotional um, start point, has an emotional cause. And so, talking to a counselor, talking to therapists, I always ask my patients, do you have somebody that you can talk to objectively, not in your family? Because that's going to be subjective added to it, that you can
Right.
just have this, because neuroplasticity is that well paved loop. So it's like that car driving around in a circle. Where's your off ramp? Where are we getting your off ramp instead of having those thoughts circulate, circulate, circulate? The off ramp is you getting it out into the ether, getting it out into the universe, writing it down on paper, and have somebody that knows cognitive behavioral therapy or emotional freedom technique, whichever one resonates with you, and decipher what those thoughts are and if they're rational, if you're ruminating, if you're magnifying, if you're catastrophizing, because all of that is going to make the pain worse. And then you almost don't even need the central sensitization diagnoses. And that's what I'm finding, is that the pain is no longer there if I'm truly dealing with what's underneath it. And so understanding that the pain is there to serve you and not to harm you. And I think if something that your listeners could take away with, that is the biggest thing, I think, is pain is here. Your body loves you. You are your body. Have the self-love, self-confidence to realize that this we only get one of. We only get one body. So it's not doing anything to harm you. It is there to tell you something. But it might not be that acute musculoskeletal thing or the migraine that you're so focused on. How do I shut it down? How do I shut it down? No, take a beat and listen. Take a breath, ground your feet, and understand that if you have the right people in your loop, if you have the right tools in your toolbox, you might not even need that diagnosis, because that pain is there to tell you something. Whether it's a relationship, whether it's you're pushing yourself too much, whether it's you're a people pleaser, all of that, it's all tied in. And it's
Yeah.
messy. It takes a while to unravel that yarn, that ball of yarn, but it's worth it, because when you peel back that layer, when you unravel that yarn, it's like, oh, okay, I can handle this. It's not as bad. And so I don't want to get into the trap of labeling, like, you know, stacking up the diagnoses for people, that now they have chronic migraines, now they have central sensitization, now they have post-traumatic stress disorder. Because then people, what I've seen in practice, that patients become those diagnoses instead of
Right.
Shabita, instead of I'm me, and that is all outside of me, right?
Right.
It's what naturopathic community, medical community needs to do in order to assess me. Yes, but the plan can go far beyond that. So yeah, something to,
It's
yeah.
kind of like, I mean, it's interesting because it is in your head, right? We say
Yeah,
it's not all in your head, but it is in your
right.
head.
Yes.
And,
Yes.
it's phenomenal that, I mean, I want to almost say, but after listening to you, that no treatment is almost needed. So I want to talk about that spinal cord stimulator. If you had to turn back time, what would the treatment just be? All the, connection with mindfulness, spirituality, dealing with your emotions. Would that have been the treatment? Or still there are certain treatments that you feel patients may need?
Yeah, really good question. I actually think that treatment isn't needed. And I think the mindfulness would have maybe been enough. Now, having said that, there's a caveat there, right? Just like medical doctors, emergency room doctors are there to triage, at the time, my pain was at such a 10 out of 10 level. I needed something to bring it down so I could even focus, to say, mindfulness, how do I get mine? Like, I don't even know,
Right.
because that 5 alarm fire. So you might need treatments to bring down that temperature, bring down that pain level from 10 to even, 8, 6, 5, whatever it is, that where you can kind of focus and say, okay, now I can deep belly breathe. Now I can work on my gut. Now I can, X, Y, and Z. But you might not need really dire treatments, interventional, aggressive, invasive treatments. And for my patients, I always say, let's go least to most invasive always, right? Always, always. Even if it's good IV nutrition, let's make sure that we're doing least to most invasive first. So we'll start with lifestyle, we'll start with hydration, we'll start with deep belly breathing, grounding, like I said, talking to a counselor. But I will say that at the time, like back in 2009, 2010, 2011, if I would have known more about the inflammation, bringing down holistic inflammation, full body inflammation, working on my gut brain connection, knowing that the body acts as a whole, there would have been interventions that would have been less invasive. So I'm talking things like antioxidants. There's supplements that you can take that would have done the job of ketamine in a safer way, with not that machine gun approach, so to
Right.
speak. So and I don't regret having the spinal cord stimulator, but if a patient were in front of me, doing the exact same thing that I was doing back in 2009, or had the same body as me, I would say, let's try these other techniques first. Come back to me in let's check in every week. If the pain is decreasing, great, we're on the right track. If not, let's book in and get the spinal cord stimulator, and then come back to me when your pain is down, that 4 to 5, whatever that scale is for you. Because again, what I love about naturopathic medicine is it's individualized medicine. What works for me doesn't work for somebody else. That's where it's, difficult for research and clinical trials in naturopathic medicine. But, everybody, we have to take it at face value and treat them as an individual. So,
Right.
yeah,
Going to
hopefully,
the supplements, I mean, you mentioned a good point. I know it's not one size fits all,
yeah,
but what are some of these examples of supplements? I mean, you're saying they could potentially do almost the job of the medication. So what are we
yeah.
looking at in terms of that?
Yeah, so if you're looking at like helping with the top down approach, right? Top down approach is going from our brain, and we've got interneurons there that are going to feed back to amplify the pain signal. Are there things that can be done that work similar to ketamine, methadone, that is going to stop that top down approach to de amplify or decrease that pain signal? Helping with the inflammatory cytokines to move from pro-inflammatory to anti-inflammatory. So there are things that can be done. I'll say, so there's a group of like probiotics, omega 3s, turmeric. I will say 99% of your listeners, and I'm just going to say that because I don't know, maybe 1% falls into the category that these won't work for them, but 99%, all patients should and can be on probiotics, omega oils, and turmeric, just to keep the inflammation down in your body, to support your gut, and to support cognition, all your cells, because all your cells are wrapped in a phospholipid fatty bilayer. So the omega oils are helping seal the lining of our leaky gut, leaky brain, and we can talk about that in another episode. But those three supplements could be used universally, whether you have central sensitization or not. If you have something like chronic pain that is, the signal is there long beyond the actual injury, something like a P Pure, which is a free fatty acid that we make normally, it's palmitoyl ethanolamide. So that helps with the mast cells, with the inflammatory cytokines in our brain, our glial cells, part of our nervous system, and those cells like neurons, glial cells are involved in that. They help to decrease that top down approach and to help with inhibition of those interneurons that relay the signal to amplify it. So P-Pure is going to come in and say, no, you can dampen that down. You don't need to react. It doesn't need to be as strong. So while you're dealing with the emotions, you've got P-Pure on board to help, dampen that pain signal. So P-Pure is a great one. It's also,
Wow,
there's no.
never heard of it before.
Yeah. So, and I used to get mine from Germany back in 2014. But now it's, readily available in Canada. A lot of nutraceutical companies are carrying it. A lot of practitioner grade companies are carrying it. So, and you can use that for musculoskeletal pain too. So if you have things like, an osteoarthritis or a rheumatoid arthritis that is going on for longer and longer and an autoimmune type of a picture, that can be useful as well, because that top down approach is useful in conditions that extend far beyond central sensitization. So that's one. And then increasing our antioxidants. There's been more and more studies with grape seed extract in being just as effective. And I mean, there's one study, so we won't go out and sing it from the rooftops, but one study has shown that grapeseed extract is as effective as opioids in low back pain, so chronic low back pain. So I'm
Wow.
really interested in that, and I just did a presentation on central sensitization specifically for naturopaths, so I included that in. So it's very new; it's like a 2024 study. So I'm sure, when this podcast airs or down the line, there will be hopefully more research in that realm. But yeah, P Pure grapeseed extract and turmeric probiotics and your omega-3 fatty acids, high EPA, is going to be really anti-inflammatory for your listeners.
Wow, that's great. Thank you so much, Dr. Teja. I mean, this has been wonderful. I mean, I think you've given us a lot of helpful information. And I want to say, you started off the bat with trust your gut. And,
Yeah.
your story was very powerful and, gave me goosebumps. But I think the take home from so many episodes and so many providers that I talk to, everybody says trust your gut. And you lived it. So,
Yeah.
I mean, trust your gut is the take home. Can you tell our listeners where they can find you?
Yeah, for sure. So I'm on Instagram, I'm on Facebook. TejaWellness.ca is my website. I recently just gave up my own practice. I was a owner of a multidisciplinary clinic, but I gave that away. And now I work at Polo Health in New Westminster, BC. I'm in British Columbia. And I work as a clinical supervisor at the Boucher Institute of Naturopathic Medicine, where I graduated. So I get to help teach and support the future naturopaths. So I really love that. But they can find me on tejawellness.ca, and they can, I'm still seeing new patients up to this date, anyways, in 2025. So they can book online. I'm on Instagram, dr.shabitateja.nd. And Facebook is linked with that. So LinkedIn, all of those. If you find me on Instagram, you'll find me everywhere else.
Perfect. Thank you so much, Dr. Teja, for your time today.
Thank you so much. A great conversation. And thanks for having me on.
Thank you, listeners and viewers, for tuning in. If you want to catch more episodes of Uncover Your Eyes, make sure to follow or subscribe on your favorite podcast platform and on YouTube. To learn more about me, follow me on Instagram at dr.Meenal Agarwal. Until next time, keep those eyes uncovered.